So this patient's coming in for removal of a lesion that's been on his upper back for how long now, would you say?
Probably a few years now.
A few years now. It was apparently incised and drained about a year ago, where they just must have gotten somewhat infected, so they put a bit of packing in. You can see here there's a bit of a communication there. So Dr. Jane, what's that look like to you?
It looks like oxidized material.
Yeah,
which
so
is
that's a
like
puncta.
pointing up.
Exactly, so that area is broken down. So this is evolving, and we just talked about this before. There's a lesion up here that we'll deal with afterwards. So this is a dilated pore of Weiner. This is what this is evolving into. Now, as the person who's taking it out, do I like seeing these here? Does that cause any problems for me? What do you think?
It might have communication with the underlying tissue, so you want to remove the...
Yeah, it definitely does. But the reason what I've been telling you though, so as soon as it oxidizes, the membrane starts to thin out. So if this wasn't like this, the membrane would be a lot stronger. So it's easier for us to take it out. So the dilated pore of Weiner's, the membrane can sometimes be very, very thin. Now this is just sort of to evolve there. So I expect if we go wide enough, we should be okay. But the membrane may be thinner because it's had some communication that's there. Any pain there at all?
No.
No. So again, to Dr. Jane's point, not that I would do a linear incision anyway, so why would I not want to do a linear incision in this case?
It's quite big and we might not...
Yeah, and there's already, you can see how tented it is, so it's going to have some redundant tissue there, so I'm going to be doing a elliptical incision for that reason anyway. But because the puncta is there, I want to make sure I take that out. Now, you could choose to go along it and just scrape along the sides, but I would just sooner avoid that and just go along the sides. But here, I'm going to be very, very thin. Because typically in areas that's distended like this, it's going to have very little space between that and the actual cyst. And again, we may have no choice here. This may rupture on it. Just dab that for me, please. But like usual, I'll want to try and see if I can dissect that down and avoid rupturing it as much as possible. Dab that for me, please. You're okay?
Oh yeah, for sure.
Let me shift it over. So this is the part that's the hardest, is just dissecting it down just very slowly. When they're a bit deeper, the dermis isn't so thin, and it's a lot simpler moving along with these. But and why do these form in the first place?
Epidermal cyst with lots of keratin inside them.
Yeah, that's what they are. But what incites them to form in the first place? Is there a theory as to why?
Continuous irritation?
Yeah, trauma is the most common one. So we see them a lot in the upper back and the lower back. You know, in people who are either like truck drivers, jitney drivers, who lift weight, any manual labor job of any kind. But you can just get them from sitting in normal chairs and being a bit unlucky. So I'm going to do this corner here. And why do they call them epidermal cells? Epidermal cysts, sorry.
Because the contents are derived from the epidermis.
Yeah, from the epidermal cell, right? So this is why it was a misnomer. They used to call these sebaceous cysts. This is a harder question, but there's one type of lesion you'll see on the face that's derived from a pilosebaceous cell. They usually happen around the eyes. Do you remember what those are called?
Milia.
Milia. So milia is the only one that really still is aptly named when you mention sebaceous components to it.
Mm-hmm.
Let's check. And you're comfortable?
Yes.
Can you grab the dull scissors for me? So all I'm trying to do here is dissect down to the point where I think I can get back underneath this. But this one's awfully wide. So you can see there, we're now through the tissues over top of it. That's right on top of the cyst membrane. So what I'm following here is, this is why the purple dots are there. I'm trying to follow subcutaneously.
Margins.
Yeah, the margins of where I'm at. This side's not quite as well dissected. You're still comfortable? So we're getting there, but slowly. Do you want to grab the
Clamps, I was
yeah,
just
please.
thinking about.
So essentially what I end up doing is I'm dissecting down both sides to see which one sort of opens itself up better for me. And since we have your extra set of hands here, I can use you to potentially hold this back, yeah.
Just because.
Thank you. Just pull that side out there. There we go. this knife that way just a bit. Alright, so I'll switch back and if you can do that on the other side. Yep, that way first. And then do it at the end here. Just shift that one back towards you. Just through here, I'm going to try and look at it. No pain there at all?
No.
Just shift this way for me. Yep. So part of what I'm running into is this is just bigger.
And deeper.
Yeah. I'm going to switch back. Which in and of itself isn't problematic. If that's it for me. That's getting there. You okay? Oh, yeah. So I'm just going to massage this a bit. Just going to evacuate this a little bit. So and typically I don't usually do this because I find there's no big difference between the incision if I leave it intact or I don't. But this one, the membrane's so big that I want to shrink that down a bit so I can work with it easier. That's nice. You're still comfortable?
Yes.
So that's hypodermis there.
Mm.
You can see it on this side too. I just want to do the come back underneath that. There, yep. Your inside assist there. Just have to get slide up. He's also got a lot of scar tissue here, which is why it seems like the scalpel's not functioning very well.
Mm-hmm.
No pain there.
No.
So this is all just back behind it. I'm gonna switch sides one more time. So this is the back. You can see that's all intact. Just where we opened it up through here. That's where we created the opening there.
Right. And got the whole capsule.
Yeah, so the capsule's intact. I don't even know how much material is left in there. There's some, not a ton. At least we know that that's completely out intact.
Right.
You're okay?
Yeah.
So again, because we ruptured this, I'm certainly going to irrigate this out. It looks clean underneath it.
You want to irrigate it?
Yeah.
Okay.
Looks pretty clean all the way around.
Yeah, not even bleeding too much.
Nope. So I'm going to just, I'll cauterize it first next to that. Can you grab the
Mhm.
hybricator for me? This is pretty minimal. Just going to lower the gain, make sure it doesn't feel it. No pain there?
No.
That's always the concern. So here we should have very good anesthesia. There's no infection here, but the back end is always where you can be surprised. That's where I'm always a little bit more careful. Looks pretty clean.
You want to do anything else?
I think I'm going to try and do 2, yeah. But this is... So the problem with internal stitches here is this front area that we had to be really superficial with, there's not a lot of dermis that's there to grab, so I'll have to do it from deeper. See how well those grab. Okay, one more.
Yes.
you have to look at the margin here too. So this is where the scalpel came up and nicked it a little bit.
Mm.
So if we don't think that's going to be clean, had this happen, you have lots of scar tissue and it's tough because you'll have it shift, and we just clip that out.
Mm.
It all depends on how that comes together. My tendency is I think I'll clip that out. Just from here, so this looks okay. We'll see how that looks like.
This was a huge one.
Sort of a little bit bigger than I would have thought. Not super huge, but it was tight, and because of the scar tissue, it was fighting us. And so that's one of the rare circumstances where I'll actually choose to open it up. Because commonly, like a lot of people who watch these videos will think there's a big difference in terms of incision size versus whether I, rupture the membrane or I don't. But there really isn't, because the incision's the incision, and you're kind of forced to work around it regardless of whether it's ruptured or not. But that was a case where it was just so tight. Just clip it out, actually. Clip it right out. Yeah, I'm just not happy with it.
Mm-hmm.
Yeah.
The deeper ones aren't going to align as well, but we should be better than that.
Yeah.
Alright, just put pressure on that right up. So clip right on the knot. Yeah. Yeah, I think we'll just put the one in. So I'm only electing on one just because there's not a lot of derms to work with, and it's sealing it together nicely, so I'll just leave that. So here I just want the basement membranes to align. And this is definitely one where I'll put a pressure dressing on, because we took out a bigger lesion. There's a bigger space that's there. And that's where you run the risk of like a post-op hematoma.
Mm.
Not so much now, because we know it's not bleeding right now, but he'll go home, sit back on a chair hard, and then a little capillary will bleed into that space.
Mm.
So all I want to evaluate here is this tissue. Yeah, I'm going to clip that.
And a smaller student.
It's okay, I can grab these. So a lot of times I don't do that specifically, but if the margin is a bit raggedy on the edge, then I want to clean that up. almost done.
Okay.
Fix that line nicely, should be pretty good. So she'll just put a dressing on that, and we'll see him back in about 2 weeks.